So we can start now.
Hi, yes. Okay, we can start. Just a minute.
Yes, sir.
So, we have seen so far, we have seen various statistical, just a minute. Yes, we have seen various things. That is, what are the reasons, what are the things which can be analyzed, what are the statistical tools we can analyze, and on that basis, we can have various ways through which we can go for the meta-analysis. This meta-analysis will help to understand the quality of various tests, and this is very important. Accordingly, when there is a meta-analysis of the prospective double-blind randomized trial, will give it as a level of evidence as a 1. That is the best level of evidence. And one thing is there, whatsoever best level of evidence is there, that will be matching with the first line treatment. Okay. Then second is prospective randomized controlled studies, RCTs we call them as a. So these are the prospectives which are continuously going on, they are not retrospective, and on that basis what is the outcome is there, that is monitored. If possibly meta-analysis again done of retrospective as well as prospectives. Okay. Now the difference between this first and second is that way very small. In both cases there is a meta-analysis, there is a prospective or retrospective. In second, retrospective is also there. But important things are what, again, quality of clinical trials, what it is, how many number of patients, what was the design, that kind of studies are taken into considerations. Okay. No, more number of cases, more number of centers, or multicentric we call it as a, more teams are there, then what kind of design it was. एक थोड़ी देर में देख के बताता, एक 5-10 मिनट में, क्लास कंटिन्यू है मेरा, है ना. ओके. So these are very very important, and this gives that where the clinical trial design was good, when this what we can say, number of patients are very high, the people has done it properly, the design was properly, the results are statistically nicely done, and number of patients were very high and very properly designed, blinding of the studies were properly done. So that kind of studies, and there are multiple studies, and we are taking meta-analysis of all these various studies. So many studies we have studied, one was in UK, one was in USA, one was in France, one somewhere in India. Like that, multiple places studies were done, and on that basis whatsoever meta-analysis there will give you as a 1. Then nextly slightly lesser than that we'll call it as 2. It is a case series, maybe a few cases, 10-20 cases were studied at Aurangabad, 10-20 cases were studied at Mumbai, 10-20 cases were done, and this is Aurangabad person has found that they are useful, then they are followed by this. But they were not blinding study, they were not like that. Only thing is, that was the case, I have given the treatment, I was knowing it, patient was knowing it. So it is not a blinding study, it was not a design. So it is just case study, simple cohort studies are there, and on that basis the results are there. We'll say that level of evidence is 3. Okay. It is case report, that is only one or other case I have found, I have tried to treat it, or I have done it observational study only. That when I have given this, then we'll call it as a level 4. And lastly, expert opinion, that means this is my feeling, I am an expert in the field. Example, I am a very big expert in corona, and I feel that now in that cases, so I am an expert, and I tell that I feel कि ओनियन के जूस से कोरोना खत्म हो जाएगा. So this is my expert opinion, people believe me, है ना, या something like that. Yeah, I'll say that this will be making this. No test, it was not done anything on patient, but this is I am expert, people believe that I should be there. So this was the level of evidence 5. And if nobody says, then there is no evidence, then it is level of evidence is 0. So these are very very important. The on that basis, as I told you, you are getting the benefit, and on that basis of that, this level of evidence, if it is the best one, if it is the one evidence, that means it is most acceptable one, it goes below, it goes less. So evidence grade, now what is the evidence grade? Evidence grade is 1, that means high. That means the whatsoever effect is there, whatsoever observations are there, it is, yes, it is plausible. That means it has every chance that it can be repeated. अगर वो औरंगाबाद में आ रहा है तो वो लंदन में भी आ सकता है, एम्स्टरडम में भी आ सकता है, न्यूयॉर्क में भी आ सकता है. So effect is plausible. It is precisely quantified because my group said that in Ghati my group was working, and it shows that when we use so and so kind of treatment, when we compare with the controls, we have quantified it and we have statistically proven that this is there, it is not vulnerable to bias because it was a blinded study. It was a double blind study. Patient was not knowing what treatment is standard, what is test. So it was not vulnerable for the bias. There was no bias into it, and therefore I will say that evidence is grade 1. Okay. That means when the level of recommendation is also 1 and evidence grade is also 1, that is automatically, or when we make the guidelines, that should come as a first line treatment. Then evidence grade 2, that is intermediate. The effect is plausible but not quantified precisely, or it can be vulnerable to the bias. So on what basis? Either your level of evidence was less than 1, more than 1, that is it was not top one level of evidence, it was the next one. So it is possible but it is not precisely quantified, or there are chances of bias. Evidence grade 3 is a low. There are concern about the repetition, plausibility, or vulnerability of the bias, and therefore nobody can exactly assure that it is correct one. Okay. Now next is the strength of recommendation. So it is a recommendation based on the consistent and good quality patient oriented evidence. On that basis, that means A. Strength of recommendation is A. That means yes, it is highly recommended. This is the best medication in that particular condition. B is a recommendation based on the inconsistent or limited quality patient oriented evidences. So maybe number of patients were less, design was not proper, or benefits were not that much found. So that was B. C, recommendation is based on the consensus, usual practice, opinion, disease oriented evidences, or case series for the studies, diagnosis, treatment, prevention, or that is based on that consensus. मतलब मैंने और मेरे 4 फ्रेंड ने consensus से decide कर लिया कि this is good one, but उसके trials नहीं किए हैं, या हमने ओपिनियन दिया है कि दिस इज़ गुड वन. ओके. या मैंने एक या 2 केसेस या 4 केसेस पे किया है, बट पेशेंट को भी बताया था मैंने, इट वाज नॉट ब्लाइंडेड, इट मे बी बायस स्टडी. मैंने पेशेंट को बताया, मुझे मालूम था कि आई एम यूजिंग दिस मेडिकेशन, फिर मैं बोलता हूँ कि इट हैज़ गॉट बेनिफिटेड, है ना, इससे मेरे 2-4 बेनिफिट हो सकते हैं. या तो वो दवाई कंपनी वाला मुझे पैसे देने वाला है, या तो मेरा नाम होगा कि इसने ये दवाई ढूंढी, इसलिए मैंने केयर नहीं ली उसको डिज़ाइन प्रॉपर करने की स्टैटिस्टिकली. सो दैट इज़ वन रीज़न, एंड दिस इज़ अ सी रिकमेंडेशन. So recommendation A is a robust evidence, and that means that yes, we should follow it. It is a provisional recommendation, and initially you can start with that, but in the meanwhile you should collect more and more information, and you should be careful about it, you should be observant about it, so that either from B it can remain B, it can go to A, or it can go to C. So B, accordingly it is there. C is a evidence being inadequate, pattern of the care is very high care is required, and again from C to B or B to A it should go, then only we can say that it is good one. Okay. So what is the health US government agency that is for healthcare policy and research, what it says about it? A requires at least one randomized control trial as a part of body of evidence. For B, well conducted clinical trials, but even if there is no randomized clinical trial, then they can accept it as a B. C requires evidence from the expert committee, reports or opinions, or clinical experiences of the respected authorities. it indicates the absence of directly applicable studies of good quality. तो डायरेक्टली ओपिनियन ही दे दिया, हमने स्टडीज़ नहीं किया, उसके कोई रिजल्ट्स पब्लिश नहीं किए, देन इट मेक्स दैट दिस वन. सो दीज आर हाउ वी आर अगेन गोइंग. एक बार पहले देखा था हमने, वापस देख रहे हैं हम लोग सिस्टमेटिक स्टडीज़. ओके, तो व्हाट इज़ द इम्पोर्टेंस ऑफ सिस्टमेटिक रिव्यू, हमने ये पहले भी देखा था, पिरामिड. सो ऑन द बेसिस ऑफ बैकग्राउंड इंफॉर्मेशन, एक्सपर्ट ओपिनियन, कुछ पेशेंट्स पे हमने किया, उसके बाद वो डेटा कंफर्म करने के लिए वी वेंट फॉर केस कंट्रोल स्टडीज़, केस सीरीज रिपोर्ट्स. ओके, इट इज़ अनफिल्टर्ड इंफॉर्मेशन एंड अनवेरीफाइड इंफॉर्मेशन. देन वी आर गोइंग फॉर कोर स्टडीज़, and later stage we are going for randomized control studies. If we are reaching to this part of the pyramid, that is up to this randomized control trial, then we are reaching somewhere towards 2 level or B level. But later when we go critically appraise individual articles which are on that basis, because good journals are there, they will take out flaws. If there are some flaws in these RCTs, then in this article these flaws will be, these reviewers who are expert in the field, they will ask so many questions and they will ask for some proofs, and if these proofs are accepted, these proofs are enough, then it will be published in the journal. That is good sign. Then on that basis critically appraised topics, that is evidence synthesis and guidelines, it can come into that. So now usually guidelines is the second one, and after that it becomes systemic reviews or meta-analysis, that after all these guidelines what is the final outcome. Even though we are following guidelines and then we find that something is working here, something is not working here, something is working there, something is not working there, so our all reviews will be collected together, and on that basis again the guidelines can be modified, they can be improved. So this is how we are doing it. Now how we are grading the evidences, what is the grade of evidences? So where grade 1A, that means systemic review or meta-analysis randomized control studies are there. 1B is at least one randomized control trial. 2A means at least one well-designed control study without randomization. Again this is very important, randomization. 2B is at least one well-designed quasi-experimental study like cohort studies. Third one is a well-designed non-experimental descriptive studies such as comparative studies, correlation studies, case control studies and case series. Then next is fourth, expert committee reports, opinions and or clinical experiences of the respected authorities. These are various conditions which are there, and on that basis you are having the grades of evidences. Okay, so on that basis of that you are making it drugs in A, B, C, D. 1 A are based on the hierarchy of 1 evidences, that is A means all the A type or A category evidences are there. B is based on more type, B type of second type of evidences, or they are extrapolated from the hierarchy of 1 evidences. Then C are based on the hierarchy of category 3 evidences and they are extrapolated from either 1 or 2 evidences. D are directly based on hierarchy of 4 evidences or extrapolated from hierarchy of 1, 2 or 3 evidences. That means what? That B can be, when we find that one evidence we have used but later we find that that was not best enough. So when we extrapolate it, then we find that no, we should grade it down. We cannot reach higher. So it will come down to the next one. This is what the gradings are done. Again this is the same table we are or same pyramid is there which is working for that. Research should be quantitative as okay, it should not be qualitative. मतलब patient को अच्छा लग रहा है, ये is a qualitative है ना. अगर if you have studied the statistics, then we have got two types of thing. Qualitative means patients say that I am feeling better. But what is quantitative? Number of days in hospital stay reduced, quantitative. Number of patients cure, quantitative. Any biochemical markers they are reducing in that particular time bound margin, that becomes quantitative. So qualitatives are not well accepted because it is mostly based on the personal feelings and personal biases, while quantitative is very, very clear, robust information. Nobody can make any change in that. There are maybe two groups, control group and test group, control group, this is the mortality, this is the morbidity. Okay, randomize the patients were randomly selected for A and B. So in A, if it is A is a test, B is a control, or A is a control, B is, what is the difference? If there is a huge difference, then if A is the test one is offering better one, lesser mortalities, lesser morbidities, lesser other benefits, then we can very clearly. So this is what quantitative. It should be quantitative. It is analyzed systematically using hard objective endpoints like death, amputations, anything it can be. As I told you, death is a mortality endpoint, morbidity, hospital stays, it is an hard one. You cannot change it, or you cannot manipulate it. Patient A with similar condition and patient B, or patient in group A or patient in group B in similar condition. Okay, so what is number of days in hospital? If it was blood pressure, then what is the outcome? If it was the liver function problem, then how these markers were changed. This is how hard things are there, which are not, because feelings, मुझे अच्छा लग रहा है, is a soft win, है ना. उसको अच्छा नहीं भी लग रहा है तो भी वो अच्छा बोल सकता है, आई डोंट हैव एनी वेरिफिकेशन, है ना. सो दिस आर, या जैसे पेन मेरा रिड्यूस हो गया, सो दिस इज अ क्वालिटेटिव. एक पाई से मेरा पेन उतना के उतना है, कम हो गया, सो दिस इज नॉट क्वान्टिफाइबल, सो दैट बिकम्स डिफिकल्ट. ऑल्दो वी शुड ट्राई फॉर क्वान्टिफिकेशन ऑफ इट, बट if it is not quantified, then it is useless. It can be qualitative, but qualitative has got lesser one. Example is as I told you, pain is a qualitative, then feeling, emotions are qualitative. Many times behavioral studies are there, depression, schizophrenia, qualitative. ठीक है, so this is qualitative, but qualitative has got लेस इम्पॉर्टेंस वेर एवर क्वान्टिटेटिव इज़ अवेलेबल. जहाँ जहाँ क्वान्टिटेटिव पॉसिबल है, वहाँ के क्वालिटेटिव की वैल्यू कम हो जाती है, और जहाँ क्वान्टिटेटिव पॉसिबल नहीं है, देन क्वालिटेटिव कैन बी टेकन इनटू इट. सो ड्यूरिंग डिज़ाइन यू शुड हैव सैम्पल साइज. मैंने पहले भी कहा था कि सैम्पल साइज इज़ वेरी वेरी इंपॉर्टेंट. जितना सैम्पल साइज ज़्यादा, उतना आपकी रिसर्च की स्ट्रेंथ ज़्यादा. देन एलिमिनेशन ऑफ द बायस इज़ वेरी वेरी इंपॉर्टेंट. मैंने कहा था कि मैं जानता हूँ, पेशेंट जानता है, ये नया ट्रीटमेंट मैं 10 बार बोल रहा हूँ उसको, वेरी गुड न्यू ट्रीटमेंट, वेरी गुड न्यू ट्रीटमेंट, वो शर्म से बोल देगा नहीं नहीं मैं उसको अच्छा ही बोलना चाहिए. सो दिस इज़ बायस्ड वन. बट इफ इट इज़ नॉट नोन, बोथ टैबलेट्स आर लुकिंग सेम, ए वाले को बी वाले को बाजू बाजू में, तेरे को कौन सी, मेरे को भी ऐसी दिख रही, तेरे को कैसी दिख रही, मुझे भी ऐसी दिख रही है. इवन आई एम ओनली, दीज आर कोडेड वन, नोबडी नोज अबाउट इट. So these codes are also not easy to recognize. So this is elimination of bias. Then you get somewhere more correct data. Protocols are very properly followed, ethics are properly followed. Then you get this proper design word मैंने बहुत सारी बार बताया था. तो incorrect sample size is probably the most frequent reason for the invalid research or failure of the research. Okay. More forget will need to be randomized than the final sample size to take into account of patient who died, drop out or lost. मान लो आपको फाइनली आपको लगने वाले, आपकी स्टैटिस्टिक्स के जो एक्सपर्ट है टीम है, उन्होंने बताया कि आपको अगर जेन्युइनली स्टडी आपका ठीक करना है तो आपके मिनिमम के भी ग्रुप में 200 पेशेंट होने चाहिए. तो आपने क्या किया, दोनों में 200 ले लिए. एंड आफ्टर दैट देर आर सम पेशेंट हु ड्रॉप्ड आउट. उन्होंने बोला अभी हमको नहीं करना है स्टडीज़ में. सम पीपल डाइड, सम पीपल हैव चेंज देयर प्लेस, उनको औरंगाबाद से कहीं जाना पड़ा बाहर. सो बिकॉज ऑफ दैट ऑल ऑफ सडन यू फाउंड दैट द नंबर ऑफ पीपल दे रिड्यूस, एंड इफ दे हैव रिड्यूस then you could not replace them, then the study become invalid. So you have to take care about it. You should not go for only minimum number, you should go for more than that. This is the formula. ये आपको statistics में सीखने को मिला होगा कि this is the formula, n is equal to number of this one. तो ये this formula gives you the how to calculate number of subjects into it. What is it? There are various errors. I'll not go in more description. It is called as a false positive and false negative. ये बहुत बार टर्म सुनी होगी. false positive, false negative मतलब जब पेशेंट्स is feeling benefited but it is not benefited, or patient is feeling that आपने इवन डायग्नोसिस में कोविड का फॉल्स पॉजिटिव आ सकता है, उसको कोविड नहीं था, डायग्नोसिस में फॉल्स पॉजिटिव हो गया, या ट्रीटमेंट में फॉल्स पॉजिटिव हो सकता है. फॉल्स पॉजिटिव मतलब क्या कि ट्रीटमेंट से ही फील दैट मेरा बुखार कम हो गया, अच्छा लग रहा है, बट उसके जो मेजर प्रॉब्लम थे, लेट अस टेक एग्जांपल ऑफ कोरोना इटसेल्फ, कि कोरोना से उसको बुखार कम हो गया, उसको ठीक लग रहा है, उसके 3 दिन बाद द पेशेंट डाइज बिकॉज ही फील दैट ही इज़ गेटिंग बेनिफिटेड. सो दिस इज़ व्हाट वी कॉल इट एज ए फॉल्स पॉजिटिव विदाउट प्रॉपर वन. देन फॉल्स नेगेटिव मतलब क्या कि बुखार कम ही नहीं हो रहा है, उसको लग रहा है, बट उसके बाकी के साइंस जो है वो स्लोली ग्रेजुअली लंग्स वगैरह वगैरह ठीक हो रहा है. सो दिस इज़ फॉल्स नेगेटिव. ओके, सो द बेनिफिट इज़ मिस्ड बिकॉज ऑफ द स्टडी हैज़ गॉट स्मॉल नंबर. बायस आई टोल्ड यू, सिंगल ब्लाइंड, डबल ब्लाइंड. सिंगल ब्लाइंड मतलब कोई भी एक को मालूम नहीं रहता है, डॉक्टर या पेशेंट को, दिस इज कॉल्ड एज सिंगल ब्लाइंड. डबल ब्लाइंड मीन्स doctor and patients both are not aware that what is actually the treatment. Okay, the Cochrane is a very big library which is collaborating with so many things. They are collaborating for the best evidences. It is international not for profit organization, and it produces and disseminated the systemic review of healthcare intervention, and it promotes the search for evidences in form of clinical trials and other studies. And it is very very important, is founded and named after the British epidemiologist Archie Cochrane, and that is very very important because that he has actually this Cochrane what we can say library is very very important for that. So there are many evidences based medicine resources are there, like American College of Physicians are there, American Family Physicians is there, clinical evidence ka one typical journal is there, then another journal is there. There are so many ways by which one can go for that. There Cochrane database is there, then family practice is there, trip database is there, then guidelines are there, even if you remember NICE guidelines, there are so many guidelines are there. So these are various ways by which you can go for. Okay, you can go for web searches, and accordingly you will get see this pyramid we are going up and up with that. Okay, so this is how, this is Cochrane and various sites. Okay, journals have got impact factor. Impact factor means it is based on very very scientific calculation, that is on what how many people read it, how many people think that it is very good and they reuse this data. Suppose I have submitted one article and my article was read by you all people differently. So you are around, how many students I can see now, around 13-14 students are there. So all these 13-14 students, they are good researchers and they are using my article as a one of the big one, important one. They feel that whatsoever data I have put is good one. So that means when these 15 people are used and they are again good researchers, everybody is using to that. So my article is indirectly used by so many people, and that is what the importance. Huh? कीर्ति दस है ना, बस 5 मिनट. So these are various impact factor. You can search somewhere else. There are many high impact factor journals are there which gives information about it. कोण आलाय का सोबत बोलून, बोलू दे, let him come. Clinical trials, I will not tell you what are various trials and how they are doing. So this is what evidence based medicine basically. So these are what evidence based medicines, and these evidence based medicines are basically making you important. What's your small topic, if it is remaining I'll just go through, and if it is there I'll let you know. Otherwise we are almost finished, because designs are there, how to make the designs. I told this is everything you will study in clinical trials later. Okay, then pilot studies, yes. Okay, I think we are through out of it. If anything is there additionally, any points are there, I'll let you know. Basically what we have to remember is what is the class of recommendation and what is the level of evidences and how they are arrived, and on that basis how we are going to recommend or how we are going to make the guidelines. So I hope you understood this. With this we are completing our syllabus. If you have any difficulties while going through, you can just put it on the group so that we can solve it. So take care and be safe about it. Okay. Any difficulties are there, you can put on group. Okay.
Yes, sir.
हाँ बोल. विद्यार्थी म्हणजे तुम्ही कसे कोण आहे कुठे असते सध्या बेंगलोरला कुठे असतेस बरं हजबंड पण तिथेच आहे हा पण होता ना लाड काही दिवस होता तिथे लाड सोडलं त्याने तो हैदराबादला माझा मुलगा पण हैदराबादला 2 वर्ष होता सॉरी बेंगलोरला 2 वर्ष होता ओके बोडके पण कुठे झाला तो हा क्विंटाईल्सला होता ना मला वाटतं क्विंटाईल्स म्हणजे काय ऐकू याला कोण आपला लाड माझा मुलगा आधी कोरामंगलला एरियाला तो वर्षभर कोरामंगलला राहिल्यानंतर दुसऱ्या वर्षी तो बेलांडूरला होता आता परत तिसरा जॉब त्याला तिकडेच मिळाला आहे कुठेतरी बेंगलोरलाच आहे पण एरिया नाही माहिती म्हणजे आता वर्क फ्रॉम होम आहे त्याचा तुम्हाला वर्क फ्रॉम होम आहे का हां त्याने पण तसंच केलं ॲक्च्युली त्याच्या ऑफिसला त्यांनी सांगितलं की आम्ही हे करत बेंगलोर खूप वाढलं होतं त्याकडे भयंकर वाढलं होतं तेच ना आम्ही त्याला सांगितलं की कंपनी जे म्हणते तू इथे येऊन जा तो इथे आला कंपनीने 1 महिना 1.5 महिना आला केलं इन द मीन वेळ त्याने दुसरी सर्च करून टाकली डॉक्टर पण नाही रेट्स पण जास्त आहेत कारण ते कॉस्टली सिटी आहे खूप त्याच्यामुळे चलो काळजी घ्या